So, hold on. Erin Sarrazin, here in the green. She is a primary care nurse practitioner in Nova Scotia, and she's been working in the healthcare system for about 20 years. She spent 12 years working as a registered nurse in both the US and Canada, primarily in the area of critical care and emergency medicine. She has a special interest in women's health and runs a contraceptive clinic for her local community in addition to her family practices. Erin is also the communications director for the Nurse Practitioner Association of Canada. So Erin, welcome. Sorry, let me just go back here. Sitting beside Erin is Dr. Maria Alexiadis. She's an experienced health leader with a diverse background in healthcare leadership and a career that spans 25 years.
35.
Oh my gosh, yes!
Don't trick me.
Oh no, this is me and my glasses. You're 35 years. She has been involved in establishing post-COVID integrated care services in Nova Scotia and has helped lead the Virtual Care Nova Scotia. Since 2018, Dr. Alexiadis is head of the Department of Family Practice in Central Zone and interim clinical lead for continuing care across Nova Scotia. At present, she holds additional roles with Nova Scotia Health, including the Senior Medical Director of the Primary Care and Chronic Disease Management Network, and most recently, Initiative Lead for the Primary Care Transformation. So, Maria, welcome. Sitting beside Maria is Lisa Woodill. She is currently the Director of Pharmacy Practice for the Pharmacy Association of Nova Scotia, and in this role, Lisa is responsible for education and conference programming, and she's project lead for various demonstration projects, such as the Community Pharmacy Primary Care Clinic Demonstration Project. Lisa received her BSc in Pharm from Dalhousie University in 1999 and has worked in various positions, including Director of Professional Development, Regional Pharmacy Manager, and Manager of Pharmacy for Ontario, Western Canada for Sobeys. In these positions, she provided professional and operational support to pharmacy teams across the country. Lisa, welcome to you. All right, and last but not least, we have Dr. Roop Conyers. He is a family physician and medical site lead at the Annapolis Community Health Center in Annapolis, Royal, Nova Scotia. He works in a collaborative care model, providing comprehensive patient care to a population base of approximately 10,000, including full-scope family medicine, emergency medicine, trauma care, procedure clinics, and palliative care. He is also the postgraduate site director for the Annapolis Valley site with Dal University, where he sits on the selection committee and residency program committee for the Department of Family Medicine. At the provincial level, he is a board member for the Nova Scotia College of Family Physicians and peer reviewer for the College of Physicians and Surgeons of Nova Scotia. At the national level, he recently completed 2 terms as a member of the CFBC's Postgraduate Education Committee and Selection of Teachers. So, Roop, welcome. Everyone, welcome. Thank you. I'll put this down now. Okay. So, I would like you to each begin, a couple of minutes, just share with everyone a bit about a day in the life. Tell us a little bit about kind of your work. We've got 4 fairly distinct kind of, practitioners here, and would love to hear a little bit more about kind of what you do, and touch on maybe some of the challenges in work for you as it stands. Yeah, Erin?
Hi, Erin. Thank you so much for having me here. I'm happy to speak on behalf of nurse practitioners in Nova Scotia. I work in a family practice, and when it was established, it actually was just me. So I wasn't part of a group model. It was just me alone in a single room. I was actually located in the basement of a nursing home initially, me and an admin, and I was taking approximately 800 people from the family practice registry. So I started doing that in 2019. Prior to that, for 4 years, I had worked for the Department of National Defense on various military bases across the country. So it was a very big change. With D&D, I'm working in a huge multidisciplinary environment. That's almost like living in mini hospitals. You basically have everything you need on site. And actually, their model is a model that, I think we could look to in a lot of ways for some recommendations. So coming from that to this model, it was a big change. I was very fortunate to have a family practice that was about 10 minutes up the road from me who was willing to act as collaborators. So that contained about 6 or 7 physicians at at that time, a family practice nurse, as well as another nurse practitioner. So they were like, she can't be down there all by herself. She needs somebody to rely on. So I would actually work there 1 day a week, and that's where the contraceptive clinic that I run actually was born. It was born from kind of a collaboration with that clinic, as they already have the equipment on site. They had a sterilizer, they have the equipment to complete IUDs primarily, and the physician there was extremely supportive, and she was like, you know, this is a need in the community, let's start taking referrals from all around and let's do that. So that's sort of where the clinic was born back in 2019. Since then, in 2021, it's all kind of merging together with COVID. I'm sure you guys feel that too. But 2021, we moved within the community of Eastern Passage, and we are now co-located with the pharmacy. And that's been really excellent in a lot of ways. It's more of a clinic type setting. We did some renovations, and it's lovely to have that collaboration and those close ties with the pharmacists. We are connected through a back hallway, so I can jet down the hallway and ask them questions. They can jet down the hallway and speak with me. So there's that really nice collaborative piece. Unfortunately, or fortunately, I guess however you look at it, the clinic is expanding. So we recently hired a second nurse practitioner, and she started about 2 months ago, and she hit 99 patients just the other day. She's taking from the family practice registry building from 0 patients. So it's going to be a long haul for her, and she's doing an excellent job. And then we're also trying to acquire, I believe there's 2 physician postings. They've been up for a while, as in many places it's been a challenge to recruit, but as a way to try and, I don't know, sweeten the pot. And fortunately, from a lot of great community support and support from the local MLA, we're expanding the clinic, and we're currently doing renovations for a larger clinic. That clinic will have, I believe, 5 spaces, and we're also hiring a mental health professional to work 1 day a week, and then potentially looking at others, allied health. That's kind of still to be determined, but it's going to be kind of a larger multidisciplinary space, which ideally for most communities I think is what you're looking for. Like, I was a good start, but I am not the be all and end all, and I cannot be the one person for an entire community. I definitely need support, and it's better for the community and better for me. In a typical day, I see 12 to 20 patients. It kind of varies. I do a mix of virtual care and in-person care. COVID was, the one positive that came from COVID was the fact that we are doing a lot more virtual care than we used to. I think the patients' feedback that I get is that they do like that for things that don't require a physical exam, or you recently had a physical exam and this is maybe just a quick follow-up, like review labs, that sort of thing. It's great to be able to just fit that into your day with a quick phone call. Currently I'm only doing phone calls. I know some clinics around the communities are doing video calls, and I know that many of the EMRs have that capacity, and I think it just all depends on the practice that you're in. I currently don't do home visits, but the new nurse practitioner is looking into that as a possibility to incorporate into her practice, just because there might be a bit of a need with some of her patients. My patient population, because at the time that I was taking from the Need a Family Practice Registry, in that community, it's mostly a young community, a lot of young families, so there wasn't really a need for home visits, so I don't do that, but she is looking into that. We have one admin that works for both of us, so it's just the 3 of us in the clinic each day. So there's a little bit more in my day about running a clinic that potentially a lot of other nurse practitioners don't deal with, because they have, say, a clinic manager that orders vaccines and makes sure the medical supplies are restocked. My admin does a great part of that job, but between myself and the new nurse practitioner, we also have to kind of incorporate that into our practice. What else can I tell you? 1 day a week, I still do the contraceptive clinic, but I've now been able to relocate that to my own clinic. We haven't completely severed ties with Pleasant Street Medical Group. We still share a EMR with them, and they are still our collaborators in terms of questions. We can freely kind of go up there and pop in, and we usually arrange kind of periodic meetings just to sort of have check-ins, just to have some support. But we were fortunate to be able to get the supplies in my clinic to be able to continue the contraceptive clinic there. And I still do take referrals from the community as well as virtual care now. So that's been a new thing as well. I'm getting referrals for my IUD clinic from VCNS. So that's been very good. I think that's about all I could tell you about a day in the life. I mean, there are challenges. It's tiny. It's a small space. There's only the two of us, you know. But there's big plans for having a more collaborative practice, and we're really excited to see what those changes will bring.
Thank you, Erin. So 35 years ago, so I was probably one of the last years that I only had to do 1 year family practice rotation in Ottawa before I became a family doctor. At the end of that year, I was offered, at that time you have to now you have to beg, borrow, and steal to try to get into specialties. I actually was offered without any interviews to go into plastics, OBGYN, psychiatry, and neurosurgery, because they all could get along with me and they knew that I knew my stuff. But I thought, no, I want to be a family doctor. I can do the most I can for a lot of people for different things. So I went back, have a bit of family practice. So I'm all things, I guess my middle name could be primary care, because all that I've done is because primary care has been such a door opener in my life. So I want to give back to what I've received. Anyway, so I did family practice, and I thought, okay, now I've done it on a one-to-one level, so I started getting involved in leadership, and I did all the Doctors of Nova Scotia stuff, I did the CMA stuff, the National Body of Physicians, and then I thought, it's time to go to the other side, to government, and see what I can do there, because I'd like to change the system such that it's better for others when I leave it, better than what I got it. And the first 6 years, when I became the Central Zone department head, that job itself was a lot of recruitment, a lot of setting up clinics, all the stuff that Erin's talking about. So I'm the one, that's one of the things in the day of my life yesterday was we were talking about all the new clinics that we want to open in Central Zone. Who we want to have staffing it, doctors, nurses, pharmacists, LPNs, that's long practical nurses, longitudinal practice, or what's the L stand? Licensed, thank you. I should know that. Social workers, mental health workers. So it's not just about doctors and nurses. So primary care is not just about doctors and nurses, and that's something I'm also committed to. So that's in recruitment. So that was the stuff of talking to all of residents, talking to new physicians coming from the UK, going to the UK and try to recruit. So that was kind of my first 6 years. A bit of a struggle, because at that time we had a government that wasn't quite invested in primary care. Even though they talked about primary care, they wouldn't understand or couldn't understand or didn't want to understand, I don't know, I won't answer for them, that primary care is the foundation of the health system. Everything starts in primary care, everything ends in primary care, and that's what I keep saying. In the last couple of years with this new government, because they did have a mandate for healthcare, they are giving me money that I can do stuff with that makes me very excited. So that's why I tell people I haven't retired yet, because I want to stick around to do some of the things that I want to get done. So that's when I took on the role of Senior Medical Director for the network, for the province. And the thing is it was called Primary Care and Chronic Disease Management, but we stuck in wellness because we understand it's more important to recognize how do we prevent illness, not just do the health of the health for the ill, but we also have to recognize the health for the ones who don't want to become ill. So those are things that we're doing right now, which is very exciting. Keep going. So the transformative, because government wanted to put investments in various things. So primary care did come to the top of that list. So therefore I was asked to become the initiative lead for the transformation for primary care. So in there, we're doing all this health services planning. So right now, provincially, we're looking at how do we plan for the next 10 years? We're looking at population. We're looking at how the population is going to grow, where it's going to go, what our population is going to look like with regards to demographics, and try to set up where all the different teams should go and how the teams should be constituted. So this thing called the Patient Medical Home, this is not something that I developed. I'd like to say I took credit for it, but I didn't. It was the College of Family Physicians of Canada who came up with the model. So we're doing now design principle in Nova Scotia to see what does it look like to have a patient medical home in Nova Scotia? What are the members that are going to be part of that team as well? Because as a family doctor, I was a doctor, I was a social worker, I gave advice for finances, I was a lawyer sometimes, I was a mental health provider, so I did everything that I wasn't trained for. So the best way of providing care for people is giving them the right care at the right time by the right person. So that is something I truly believe in. So we're there now. I think the government is letting us do those things that we need to do. So we have all these plans. We're working like crazy. I was on my vacation last year in Greece, and I took meetings there because it was very important to have those meetings. So I think to say that in the day of my life, just yesterday, the first couple of hours, I was talking about all different clinics that we want to open up in Central Zone, and how do we do that based on the budgets we're going to get, and how many people are going to be there, how many people it'll cover, how many people will be engaged and attached. Then I had a meeting about long-term care, because we're trying to find a way to be able to care for people in long-term care facilities and maybe keep them well at home longer. I talked to a physician who wants to retire, but I don't want her to retire yet until we find her someone to fill in. So I'm trying to figure out a clinic that I can try to connect her with to keep her practicing longer. A brand new doctor who wants to start in September, not sure what she wants to do, so I'm telling her all the opportunities. So I'm basically doing a little bit of everything, and it wasn't until 10 o'clock last night that I said, oh my God, I have to go Summers tomorrow, I forgot. But I'm very happy to be here, and I'm here to answer all your questions. I think the one thing is that as early on, I knew that primary care was not just physicians. And so I basically respect all the other healthcare providers, because so my clinical work right now is in psychiatry, so I work with early people with schizophrenia, and it's a team-based care clinic. I love it. We have an OT, we have a social worker, we have the psychiatrist, we have me, and we have like people come in, like the pharmacists will come in and out. It's the way to work. So that's the kind of practice. Now, the other good news that you may or may not have heard of in your last couple of days is doctors right now are voting for a new contract. I am thrilled. I can't give you the details because it's not ratified yet, but a lot of the things that we had communicated to government and to medical affairs and NSH that we wanted to be able to promote the patient medical home model are embedded in this contract. So it's going to encourage that kind of work where physicians are not going to be as upset, because since COVID, it's been a hard run for the physicians. And even though there's so much work for everybody, you may hear sometimes doctors are complaining because they don't want to work with pharmacists, they don't want to work. They do, but they're just frustrated because things are happening to them than with them. So I think that's really the truth. It's not that we don't want to collaborate. So I really have to throw out lots of bouquets to the physicians who kept the system running when COVID happened. I'm not sure if you realize, but family doctors are given 2 masks during COVID to make do every week while they're seeing patients. 2 masks was all allocated to them. That was like ridiculous. So again, they've done a lot. They fill in a lot of gaps. This contract will allow them to work with other people better, also pay for the work they do, so they're fairly remunerated. And so I think it's going to go a long way. So for me, I guess I'm a Pollyanna by nature, but I'm even more excited now. So thank you for having me here today.
Those are 2 very interesting discussions and lots to follow. So I guess I'll start with just talking a little bit about my own personal journey over the last 5, 6, 7 years, and how I got to be where I am today, and where my thoughts and why I have the thoughts that I do. So I started with the Pharmacy Association in 2016. Pharmacy Association represents both pharmacists and pharmacy technicians. So we do also have a regulated healthcare professional in Nova Scotia called pharmacy technician. Most provinces are starting to have that professional as well, but Nova Scotia was one of the earlier adopters of that regulated profession. So we represent both care providers. So in my role, I do professional development and training and education for those, for our members. But also probably more relevant for this group is I help to lead demonstration projects to show where pharmacists and pharmacy technicians, how we can impact patient care, where we fit into the healthcare system, how do we fit into primary care, and what can we do to optimize our role and maximize our scope of practice as both pharmacists and pharmacy technicians. So I started with, we had a collaborative care project that Marie was also involved in, where physicians and pharmacists were collaborating together for chronic disease management. Next project was one called Community pharmacist-led anticoagulation management. So patients that took the blood thinner warfarin normally have to go to a lab for a blood test called an INR on a regular basis. So we instead had a point of care test device in every pharmacy that was participating, and they could do a finger prick blood test right at the pharmacy, get their INR result, and then the pharmacist could do the dose adjustment right then and there. So that was a really successful project. We collaborated with physicians and nurse practitioners. We had 225 physicians and nurse practitioners that referred patients to pharmacies for this particular service in that project. So it was a really great sort of first step, I guess, at true collaboration with various providers working together to help patients do something new and different and unique. Made it easier, more accessible for patients. They didn't have to go to a lab, they didn't have to take half a day off work, didn't have to have a caregiver drive them to an appointment at least once a month, if not more. And then they didn't have to wait for the results. There was no phone tag trying to track them down. They got it right then and there, and the pharmacist could tell them this is what your dose needs to be today. So it was very successful, led to funding, so it's now funded for all Nova Scotia residents. We have about 100 pharmacies in the province out of 315 that are offering the service. So it was just a really good example of, okay, what else can we do? So what's next? And so we've continued to do small projects, so on very specific disease states. So if there's a hypertension project, we have a project underway currently about, it's called optimizing medications. So essentially helping patients to, in many cases, get off certain medications that they may not need to be on anymore. And those are both currently underway. But I guess the lesson learned from all these little projects was, well, what happens when we put everything that we can do all together into one project? And what happens when a pharmacist can provide to patients in their community everything that's within their scope of practice? We don't have to worry about funding. We don't have to, so some of the barriers that are currently still in place in some areas, what if they were removed? So what if everything was funded, it was part of the healthcare system, and you went to your pharmacy to get that care? So that's where the Community Pharmacist Primary Care Clinic project came. So in February, we opened 12 clinics in sites around the province, and the sites were selected based on communities that had the highest number of unattached patients, or patients that didn't have a family physician or nurse practitioner following their care. And it was quickly perceived to be it was going to be very successful, and we got further funding. So we've now opened another 13 sites from between May 1st and June 1st. So now a total of 25 operating in the province. And patients, as long as you have a Nova Scotia Health card, there's a list of services that you can come to a pharmacy for and receive care. So if you need a renewal on your medication, you book an appointment. It can be, you can call or you can book online. You go to a pharmacy, pharmacist does an assessment to make sure it's still working for you, that you're not experiencing any side effects, that there's no red flags that might require referral, and if so, they can prescribe the medication. Or if there is something that maybe needs to be adjusted, they can actually change your dose, they can substitute it for a different medication, and support patients in that way. So that's one service that's been very popular, is the renewal assessments. Another one is we had approval to do an assessment and prescribing for strep throat. So I think there have been 8,500 strep throat assessments in the province since February at community pharmacies, meaning many of whom would have gone to an emergency room or gone without care for too long if they hadn't been able to get it at their community pharmacy. So that has also been an extremely successful particular service. There's a list of 31 what we call minor ailments that pharmacists in Nova Scotia can prescribe for. So if you think about the types of ailments that you might typically start with something that you buy in a pharmacy over the counter, so eye infections, eczema, heartburn, diarrhea, nausea, those types of things, pharmacists can actually prescribe. So often you might start with something over the counter, it doesn't work, and then the pharmacist can do the next step. They can do an assessment again and decide if it would be appropriate to prescribe for that particular ailment for that person. And then also some support with chronic disease management. That particular service has been particularly of interest for patients that don't have a family physician or nurse practitioner following their care. So they're coming into pharmacies for hypertension, diabetes, asthma, COPD. Pharmacists are seeing people that are saying, I haven't seen a provider for 2 years, I haven't had blood work ordered, just barely getting by and not being well managed at that particular point in time when they arrive at the pharmacy. So in these clinics, pharmacists have been enabled to order blood work. So if it's something related to the medications that they're taking, they can order blood work and at least get them the results to see how they're doing. And help to support some lifestyle management, if there's other factors that can be changed, look at their medications for those patients. So that's also been really, really helpful. What else should I say about that? So it's in person or virtual are options at these clinics. Most has been in person, but I do think there's a lot of opportunity for virtual care, I think, in the future as well. My personal background with virtual care, I also, for the last, I think since 2012, I started collaborating with a family physician around 2012, 2013 in a travel medicine clinic. So it's a privately funded service. It's not publicly funded in Nova Scotia from any provider. But I met a physician. We both had an interest in this area and had done a specialty certification called Certificate in Travel Health together, and decided to open a clinic together. And so I had that sort of first experience of collaborating directly with a physician. So we had 2 rooms. I'd be in one room, he'd be in the other room. We'd both do assessments with different patients at the same time. At the time, I didn't have the scope of practice to prescribe for that. So he would then come into my room. When I was done, I'd say, this is Mrs. Smith. These are her medical conditions, allergies. This is where they're going on their trip. These are the vaccines they need. These are the medications I think they need. He'd have the opportunity to also discuss with the patient, and then we'd be able to, he would be able to prescribe for that patient anything they needed. Fast forward to today, I actually do have the scope of practice that I can now prescribe. So I eventually did start working independently, but I had this wonderful experience of being able to work first with another healthcare professional and be able to work alongside and learn from each other. I think he learned from me about what pharmacists can do, and he would often be coming to ask me, okay, well, what about this drug interaction, or what about this situation? And I would be going to him and saying, well, that she has this particular complex medical condition. What do you think about this scenario? Sometimes we had to refer people, for example, to specialists and different things. So wonderful experience. And all these sort of, the other, I guess, piece of that was that it was an appointment-based service, which pharmacy at the time didn't do a lot of. We, at the time, had, anybody came in at any point and could ask a pharmacist any question at any time. And later, once we started to be able to provide certain healthcare services, could sort of come in and ask any time. And it became a very hectic environment in a pharmacy, with pharmacists sort of doing multiple roles, I guess, all at the same time. So you might be looking at a prescription, assessing for drug interactions, and then somebody comes and says, can you give me an injection? And then somebody else comes and says, can you renew this prescription for me? And then you go back to looking at a prescription. And so we were very torn in a lot of directions. And so another, I guess, lesson learned from my experience working in more of a clinic-based setting, and some of the demonstration projects that we've run, was that we could do this in a more organized and efficient way. And so another concept that we're really studying and looking at in this project is a new model of workflow for pharmacy. So really separating out clinic time versus your traditional dispensing roles that we had. So we have dedicated clinic time. So the pharmacist does only appointments when they're in the clinic. So they're booked, timed. They see patients, they can focus on the person that's in front of them, finish what they need to finish with that patient, and then they go on to the next patient. And then the next day they might be working their traditional role. So it's all the same pharmacists rotating through the clinic shifts, so everybody's learning together, and it's so far been a wonderful experience. So I'll pass this along.
Thanks. It's wonderful to hear the different path and everyone's perspective. So thank you. So first of all, thank you guys for the invite. I appreciate it very much. And I'm excited to share a day in the life of I will say, a rural family physician. So I think to understand a day in the life of my world, you kind of probably have to understand my environment first. So I trained in Ontario. I had 6 years of surgical training before I came to family medicine. And I trained in the collaborative environment, so a team-based environment. So when I came to Nova Scotia, I sought out a collaborative group to work in. That was about 14 years ago. And as you can appreciate, 14 years ago in Nova Scotia, there weren't many groups here. In fact, there were only 2 groups. And I was wooed. I went to different communities, and it was great to see different communities, but there was only 2 groups in the province that remotely fit the definition of what I was trained in. And I think that's an important element as you begin the discussion about recruiting physicians and the environment they're going into. So my environment when I came was Annapolis Royal. So I'm a rural family physician there. I work with a group of 5 other physicians. We work in a building that houses our primary care office and a hospital. That hospital used to have a 24-hour emergency department. It now then transitioned into a collaborative emergency center and is now transitioned into an urgent treatment center. So we have 5 physicians. We also have on our team a nurse practitioner, a family practice nurse, we have a dietitian, we have a social worker, we have mental health, we have physiotherapy. I'm sure I'm missing some group there. But essentially, it's a team. It's a multidisciplinary team. We also interact daily with our community pharmacist. So we have scheduled interactions with our community pharmacists on a daily basis. So they're also part of that team. And the point I'm getting at is my environment, and as you heard at the start, I wear many hats. My environment is not just primary care. It's primary care with a team of individuals. So my day typically starts at around 7:30 in the morning. I get to the hospital, I ran on the inpatients. At 8 o'clock, I have rounds with the team. So that team involves, again, the physicians, the nurses, because we have nurses that run the emergency or the hospital inpatients. So that morning rounds begins with nurses, the physicians, the nurse practitioner, the dietitian, the diabetic nurse educator, physiotherapist, social worker, and if we're in infrequent times, other specialists that may need to be part of that table will join. So it's a large group. So my morning will start there. I then, depending on my week, I'm either in my primary care office or I'm doing a procedure day. I tend to do 1 or 2 procedure days a month. I accept referrals from all the physicians in my community. So given my training, I do a procedure day for different things, anywhere from simple things like punch biopsy, all the way up to wide excisions, toenails, and short-lead vasectomies. So we do a fair bit in terms of our procedure clinic. And that was driven by the need of the community. So I'm in Annapolis Royal. The next regional center is an hour away. To Halifax, it's about 2.5. If you take the speed limit. I've learned that the hard way. So that was driven by the need of the community. We each, as a family physician there, we also run the emergency or the urgent treatment center now. So 1 day a week, I'm in the urgent treatment center. That service is focused on providing care for unattached patients, but also acute care for attached and unattached patients. And I can talk about that later as the discussion unfolds. Then I also, as you've heard, I take part in medical education, a passion of mine. I've been fortunate in my training to have been mentored by wonderful individuals, and I think, as Maria pointed out, part of our role as physicians is to give back, and my colleagues all feel the same, and I've been fortunate to encircle myself with colleagues that share that vision and that passion for medical education. So we have 2 family medicine residents with us all the time, so we teach every day. We also have clinical clerks, so that's another ball we're juggling in the air. And so you can begin to see, as I entered the door of the hospital, the moment I entered that door, I've got multiple balls in the air that I have to juggle. And that's just not me. I think that's the role and reflection of most rural family physicians in this province. So as a primary care deliverer of primary care, you're doing that in the context of many, many balls that you're juggling. And there's many demands of your time. And so when I'm not in my office, patients' perception is that I'm not in my office. Well, really, in reality, I might be in your treatment center, or I might be at Kentville doing medical education, or I might be in a meeting, or I might be working in community. So physicians may not necessarily be in the office, but they're delivering care in different areas and different venues. So they're always on service. So as I run through my day, I start at 7:30. If I'm fortunate, I leave at 6, if I'm fortunate. And that typically is, and then 1 week in a month, I also am on call for the hospital. I'm also on call for the inpatient 2 nights of the week. So you can begin to see, as a rural family physician, and I also say urban family physician, the demands of your time is endless. And so when we talk about delivery of care and access, I think most of us are doing this to look at access, and as you probably heard into mixing and the theme there is quality, right? So quality and continuity should all be part and parcel of the word access. So that's a kind of a quick snapshot. I realize we need time for questions, so I'll leave it there, but that's a snapshot of my day.
Thank you. Thank you. Thanks to all 4 of you for so complex system, so much going on, incredible different kind of practice settings, but desire for collaboration, desire for team-based care, and the value and working towards that.